So, hello again. Shall we start with the synthetic clinical health record challenge? So I'm going to make an introduction for you to know how we have prepared the data. But before to start with the preparation of the data, let me wait you for your picture, David. So let me start with this, which is this section of the medical act. So typically, when we see a patient, we obtain some data, some information from the patient, and we compare this observation with the knowledge that we have. That can be biomarker, but can be anything, and we take a decision, right? So point is where this knowledge come from. So this knowledge come from studies in which, for example, clinical trials or whatever, in which we have compared cases to controls or different type of studies in which we concluded that this biomarker is associated to a high risk of this disease or is beneficial for a treatment or whatever. So the point is that during the last 15 years, all the health system have digitalized, systematically digitalized. Because what we did in the very beginning was that observation were paper, so absolutely useless for systematic data analysis, or they were containing in laboratory solutions which cannot be put all together. But nowadays we have this possibility, so this data centralization in which we can collect all this data. When we extract the data to the patient from the patient management, we call that primary use. So we extract the data for a purpose. But I'm not taking a radiography of the patient for publishing a paper. So if I going to use this data for a different purpose, this is secondary use, and it has a lot of legal connotation. This is one of the problems with which we have to deal continuously, right? So let me introduce you our data lake in Andalusia. So this do you have a pointer somewhere? Or well, okay. So this is Andalusia. Here, this is south of Spain.
Can you use cursor?
No. Yes,
Oh,
yes. So this is Andalusia in the south of Spain. So this is the biggest region in Spain, and this is the third region in Europe. So the size is 8.5 million, and the size is like a country, a medium European country like Austria, for example, or Switzerland, and it's bigger than other European countries. So anything that we do at the regional level is like if other countries did it at that country level, right? So all the country, also all the region is digitalized with a unique health system. So all the information is homogenized across all the region. And these are some figures that you can see there. We have 15 million patients accumulated since 2001. We have 9.4 million of users, which is 1 more million than the population, and probably is due to people in transit or to people from Europe which lives part of the year in the southern coast of Spain, which is very nice for a Norwegian or a North European. So, but look at the figures. So we have 500,000 of hospitalization per year. We have 80 million of uses of primary care, 7 million emergencies, 2,400 million of analytics, right? 859 million of diagnoses, 7,000 million of images, different type of images, a lot, right? We still don't have genomic data. Now we are trying to set up all the system to collect this data, but we are starting to collect the data from the pathogen surveillance. So we have 40,000 genomes of SARS-CoV-2, right? So the point is, why are we are not? I mean, we have so many data, and actually, do you know how many data, clinical data, are in the world, in the entire world? Guess. 1/3 of all the data in the world are clinical data, have been obtained in the context of clinics. So that means that for every 2 videos of cats in YouTube, you have one radiography or whatever. Yeah.
Where did you get these numbers?
It is in this publication. I can give you a pointer. Typically, I have a reference, but I don't have it. But you can take a picture, or I can share the presentation later. So why? Because this is, I mean, in Europe, in different countries, you have different laws, but in Europe, we have the General Data Protection Regulation, and this is the Article 5, in which they say that the data are collected for specific purposes and will not be further processed in a way which is incompatible with these processes. This is what I said before. If I have a radiography, if I get a radiography for my patient, it's not for making a paper. But so this secondary use can be done, but it's a little bit more complex, right? And there is the recent European health data space has defined the actors of who can deal with the data and establish procedures, the procedures for the medical data, how it is to be used in research, right? Because GDPR only speak about rights of patients, and the EHDS talks about the procedures, right? So that's the paradox that we have. So we have the health system with the data and with the doctors who know what are the relevant questions. And on the other side, we have the data analysis skills and the computing facilities. And this is a structure which is obsolete design that is inherited from the time in which the hospital only produced paper. So the data were produced on purpose for any specific research. But now we have the completely different situation. So the data is produced and stored in the health system. So there are a lot of problems that you probably know. I'm not going to extend on that, but I mean, health data is very easy to be identified. So you cross the data, the patient histories with social networks. For example, you can identify easily people, and there are more sophisticated ways of identifying, and there have been many cases in which that have happened. It's not possible to anonymize data set and put this data set for public access, because the perfect anonymization means a degradation of the information that probably made the data set unuseful. So one of the solutions, and it was actually suggested, we started that 2 years ago, but now it's exactly the solution that they have suggested in the European health data space, which are the trusted research environments. So the idea is bring the algorithm to the data instead to bring the data to the algorithm. And the point would be to essentially to put or to provide computing capacity or access to this computing capacity to the health system, because the data is there. So that would solve all the problems. This is not the only way in which you can build a trusted research environment, but this is the easier. But conceptually, the easier, but the implementation is not that easy. And actually, you are not going to see many trusted research environment already. Probably we will see more in the future. Actually, we set up that one, which is the first one, which is active in Spain, and actually we got an award from ISMB, which is a business school, European business school, and Novartis for this initiative to improve patient care, etc. So we have this in place, and we can even open this this structure, and actually we open to companies for. I mean, they give us protocols, and we do all the legal stuff, and we make the role of a CRO, and we work for them, and we get paid. So all the system is self-sustainable. Right. So this is a solution. So what we do is, instead of anonymize the data and extract the data, we use the data within the health system. And actually, we don't need to anonymize, we pseudonymize. And this is very important because for some studies, you may need to re-identify a patient. For example, we have had a couple of studies with patients of rare diseases in which we wanted to find patients that were under the radar but have a rare disease because there is a cure or there is a treatment for the disease, and we need to identify. If you identify in an anonymized data set, there is no possibility of re-identifying the patient, but here we can re-identify. So in principle, it would be a solution, but what is the problem with the solution? Scalability. So if you have all the data there and you have to pass through all the ethical, etc., and you rely on the capability of these teams and on these equipments, you have a bottleneck there. So, So there are other possible solutions. One of them is simulating patients. So there are several ways of simulating the patient, but probably the most interesting one is not the. I mean, you can using the knowledge on the variables of the distribution of the variables in the patient and the relationship between the variables. You can try to simulate patients, but point is that the simulation are realistic, but there is not much room for the generation of new knowledge because you are simulating what you already know, right? Something that we can do is to use different techniques in which you can do this. Sorry, this is unrealistic. So what we can do is, so we can try to simulate patient using artificial intelligence, different techniques of artificial intelligence that allows us to simulate data and to capture the relationship between the variables, even if we don't know beforehand, right? That would be the idea behind. So we choose simulating diabetic patients essentially because there are a lot of them. So it's very, very prevalent disease. So we will have a big number of this data. So we have in the range of 1.2 million patients with a diagnosis between 1938 and 2019. These are several data, but we have in a total of 6 million of medical visit and 7.7 million of diagnosis. So the diabetes diagnosis plus other diseases concomitant with diabetes. So there are different ways in which we can do this simulation of synthetic data, and we have started by generative adversarial networks, which is some people have already tried, and we tried with this again. So maybe you are familiar with this. So this is a generator of pictures. And actually, many companies use that. Many publicity companies use that. Instead of hiring models, they pay a company of this and say, okay, give me several pictures of young people with the bicycle, laughing, ha ha ha, whatever. So you prepare that, and you don't have to pay people, you don't have to pay image rights, etc., etc. So you can do that, and you can try to guess what among all these faces are real and what are simulated. Try to guess. Well, or none is real. All are simulated. You can find them in the web page. So it's very funny. So essentially, generative adversarial network is a combination of two deep networks. One of them is a generator. It generates from random noise something like faces in that case. And you have also a discriminator. So you put them in competition. So in the first stages, it's very easy to distinguish between this random noise and the real information. But what happens is that there is a feedback. So the discriminator tell to the generator why it's distinguishing between both. So the generator then corrects and tries better. So they enter in competition after several thousand of million or whatever of rounds. Finally, the discriminator is unable to distinguish between the real data and the simulated data. In that moment, you have a generator perfectly trained for making realistic faces. Actually, if you remember the faces that the picture that we have seen, they are quite realistic. So you have a boy, you don't have that in the eyes. There is not gray hair. So it captures the relationship between the variables. So all the faces are quite realistic. So the idea is to do the same with electronic health record to show the network how electronic health record of a diabetic is, and to try to simulate something similar. So at the end, we use a combination of autoencoder and GAN. And in the first stage, we have a very simplified version of a patient, which is that would be a disease trajectory. That would be the visits, and any visit has associated diagnosis or symptoms, right? So at the end, we have a list. We have first a gender, assignation of gender, and then a list of visits with the diagnosis, right? No more data for now, right? So that would be an example. We have this code for male and female, and we have in the first data set, the age was coded in decades, so it was a low resolution data set. And we have these visits, and this is what we got, more or less. This is the input. We excluded patient with no gender, no birth date, and with diabetes diagnosed before 2003 to have more data on the patients. This is what happened with real world data. So sometimes you find strange things. So we have found, for example, testicle cancer in women diagnosis, or ovarian cancer in men. I mean, it happens comparatively very, very, very low, but there are some errors. So we have to sort of clean a little bit the data. This is the distribution of data that we have after this cleansing. So at the end, we have total of, so the input will be a little bit less than 1 million, and up around 4.8 million of medical visit and 6 million of total diagnosis that we have used to train the data set. So this is a comparison of real data and no, sorry, this is the diagnosis frequencies synthetic versus real. So I mean the number of diagnoses. This is the number of diagnoses per patient. So in terms of number of diagnoses per patient, is more or less is correlated. We found what we expect to have it from the real data. If you see there is a little bias. So since there are more patients, you see here. What is the here? So there is a small bias here. So because since there are much more patients with a low number of diagnoses, it learns better and it builds more of this. It is the typical bias, training bias, but we are working on that, right? This is more interesting. This is the disease co-occurrences. So, and the disease co-occurrences are quite consistent, right? So this is important because it's learning that after this disease comes the other one, and this is important, right? And also when you cluster the disease co-occurrences, they are quite similar between and it's not happening by random, but it happens with some disease like cardiovascular disease and occlusion of stenosis arterias, or ischemic heart disease and heart failure, diabetes and hypertension. So, I mean, it makes sense, right? And this is also consistent between the two data sets. And also with the disease trajectories. So 7 out of 10 trajectories are matched. So we missed that one in between in the real, we missed that one in between, and he invented a couple of them, but essentially it preserved more or less the trajectories. So that would be the data set that was available last year, the low resolution. So, I mean, in principle, it looks close to real data, and the co-occurrences and trajectories are reasonable, similar to the data. So what we did this year is to prepare something similar, but with the resolution, with a year's resolution. So instead of being a chunk of 10 years, it's 1 year resolution, the patient, right? So we have a more detailed age, when we describe the patient is more detailed in time. We have more resolution, but for the rest of things, is more or less the same. So this is the number of patients that we have used, and these are again the correlation between the diagnosis frequencies and the real data and not real data. And these are more or less what I showed you before. We have more or less the same problems, but at the end, what we have is more resolution in the data. Same with the co-occurrences, so we find something very similar. And same with the clusters. So we found the same cluster, but we have more resolution in the data set. So it's a little bit worse, but it's not significantly different, the metrics. So we get more or less the same metrics. But what we have is better resolution. This is what we are offering this year. So that would be the conclusion. So this is this year's data set that we are going to see. So let me put a couple more of slides to show how important and how disruptive can be the use of the data, and especially on the side of trying to make more predictors and better predictors, trying to obtain better predictors in health. So this is what I showed you before, and typically what happens is that we have this patient, but when we have this patient on the clinic, it's because the patient has the disease. So the health system is clearly reactive. So when we have a patient, it's because the patient has the disease and is very bad. Probably is with the condition very advanced already. and in many cases it's too late, right? So the idea is with good predictors, we can make the database part of the primary use. We can use the database if we accumulate the data of the patient, in our case, on a monthly basis. It depends very much on the health system, but we were accumulating data that are being generated by our patient, and we can say, okay, you have in risk of having this diagnosis in 1 year, for example. So you go to the health system. You go to the health system, and probably is good for you, and it's good for the health system. This is one of this strange situation that something which is good for the health system and make the health system more sustainable is at the same time good for the patient, because typically there is a negative correlation. And this is for you to see the data on the cost, the cost per ages, which is related obviously with the use of the health system. So what you have below this blue part is drug consumption. So drugs obviously is the most expensive part, but the other big part is hospitalization, right? So what we have is an increase in medication and in hospitalization, which is a lot of cost. But you see, for the rest of, obviously at in the beginning, so the kids are very expensive. You all know. But for the rest of things, for the rest of primary care, etc., urgencies, etc., in which you leave your data, is more or less the same usage. So you are getting data across all the range of ages, but you can be predictive. So you are predictive, you can be saving a lot of money and a lot of resources in hospitalization and in drug. And on the other hand, it's good for the patient because the patient will be healthier. So nothing else. So this is the challenge for this year, and something that we can do and we offer to do every year is to, once these synthetic data are analyzed, etc., you build up a predictor, we can check and validate the predictor with the real data. It's something that we are planning to do. So no more than this. So this is the people who have collaborated. It's Carlos and Francisco, which are working with me. Well, Francisco moved to Universidad de Granada. Lola Muñoyerro and Roman Villegas, who are working in the BPS, and David, who is collaborating with us in all this adventure. So thank you very much. And now we can start with the, well, if you have any question, I can be happy. Yeah. Ask.
If I may,
Yeah, sure.
I would respectfully disagree about general kind of synthetic data. I would argue that synthetic data should be purpose-specific. Because, for example, imagine that you do a geographic study. If you are interested in what's happening in different parts of Andalusia, right? And it's different from time series, for example. So for different tasks, you probably want to scramble different parts of data. You can still have data anonymized, but it really depends on what you want to do downstream.
Yeah, I agree. This is a very preliminary data set. So we have data from geographic location of all the patients, and we have data from socioeconomic data. And we know that for some diseases, and especially for this diabetes, is very dependent on social level, etc., etc. So this is something that we can also include in the data. So in theory, it should be captured by the data set, and it will produce different histories in patients from different places or from different social background. This is something that can be simulated in theory. And actually, for the next data set, we are going to use a different strategy. We are using these diffusion models that are used for generating images. And we code the patient. We have some data on that now. Probably for the next year, we will make available a more detailed patient data set with analytics, etc., etc. But we can code not only sex, diagnosis, etc., but also analytics and also drugs, things that are punctual. At the end, you get an image which is horrible, but this guy Curro Francisco, he knows, he sees the image, say, look, but this is taking that and that, and he has whatever. So it's a series of dots there. But so finally, we are working around that.
Thank you. The question that may be tangent to what you talked about, but I want to still get your opinion on this. Do you think that these simulation studies and this generation of new data studies, could they be used to create more, for example, instead of going around the problem of ethics and data access, could we use this to go around the problem of sample size? For example, like in certain omic studies for certain diseases, we simply don't have the numbers to perform very strong studies, but we may have small sample size that maybe could be used by an hyper-saturated generative model to create every sort of association that could be seen by a very precise model, but that needs to be detangled by association studies. What do you think? Does this work, or is just not?
Actually, this is augmentation, data augmentation, and there are a lot of techniques that allows you to do that. We haven't tried yet because we're now focused on that, but we tried with genomic data to try to generate genomic data in a way in which the system learns how a rare disease patient is and generate new data. And it's quite interesting because at the end, what is interesting is that the system not only obviously pick the obvious mutation of the disease, but picks the linkage disequilibrium. So other mutations that are linkage disequilibrium are captured. So the patient in the chunk of DNA that you generate is more or less consistent with the disease. It has the relevant mutation, but it has also other accompanying mutations.
Yeah. Did this model potentially picked up independent loci that still made sense with that disease by any chance?
Yeah. This is what we did.
Okay. Thank you.